So good afternoon. We might proceed with the final session of the day, of what's been a really, really enjoyable and informative day. There's a bit of housekeeping beforehand. Can anybody who has the facility to tweet, please tweet the hashtag DemPal about the meeting. And anybody who has any comments as well that they wish to have discussed as part of the synopsis later on, can they kind of just write them up and they'll be collected at the table. Somebody will be going around and collecting those. We now come to the plenary talk of the day, and it gives me great pleasure to introduce Professor David Oliver, who's a recently retired consultant in palliative care medicine from Wisdom Hospital in Rochester in Kent, but he remains in clinical practice and is honorary professor at the Tizard Centre at the University of Kent. Has a vast experience, publication and lectures in palliative care neurology, and in particular in motor neuron disease, and recently chaired the AIIHPC guidelines for neurological conditions. So with no further ado, I'll hand over to Professor Oliver.
Thank you very much indeed. Thank you for inviting me, and thank you for staying as well, because it must be tempting. So as has been said, my particular interest has always been motor neuron disease and that neurodegenerative disease, and we've increased that into other neurological diseases and to some extent dementia, and I know I haven't got a lot of experience in dementia. But let's look at what the issues are. We're looking at a lot of different diseases, but I think from what I've been hearing today, a lot of the problems are very similar. There are differences according to the disease groups, but there often is cognitive change, there often is mobility issues and other specific issues. But the numbers are very, very variable. A lot is talked about motor neuron disease, but I know we're a very small group. And I think as we'll come back, when we talk about hospice and specialist palliative care, as was said earlier, it was always seen as cancer. However, one of the very first patients admitted to St Christopher's Hospice right back in 1967 was an MND patient. And so hospices have been involved with MND and other neurological diseases to a lesser extent. But I think it's a challenge to try and help people to see what the needs are of patients and families and how we can respond to those. I've been asked to sort of talk a bit about what the research agenda and activity that's being suggested. When we look at the dementia and neurodegenerative diseases, an awful lot is said about cure and prevention. Mr. Cameron's wonderful dementia is, in the UK, is we'll cure dementia completely. It will be no more of an issue in X years' time, preferably by the next election, because then you'll all vote for me. May not be that easy, but there is a real issues about care. Are we looking at the time of diagnosis? And that came up this morning. There's this, you're told a diagnosis and then left. The support for patient, for family, and then we get into this great linguistic problems. Are we talking about supportive care, chronic illness care? There are people in long-term institutional care. Then there's palliative care and specialist palliative care. And then end-of-life care. And everyone means different things with all of those terms. I think, as Adrian said, one of the biggest problems is that palliative care and hospices get associated with just end of life. The end of nice guidance on the care of the dying adult patient was talked of, and that's really 3 days, the last 3 days or few days. But we're looking much longer. And I'll come back right at the end of how I can see palliative care and specialist palliative care being involved. What do we know about palliative care? We've got some statistics, we've got some of the issues. But probably, and I think what this meeting has helped, is should we know? Do we know about some of the care needs? Are we hearing the issues from patients and families and carers? And I think there is something about the issues for society. I was saying in the coffee break just now, if spending £50,000 on the care of people with dementia would save £250,000, that sounds pretty good value to me. Society doesn't do that, but the new chemotherapy drug, which costs £50,000 per patient, is immediately given to 10 patients in an area without anyone thinking, because it must be good, because it's wonderful care. And what we're talking about is, whatever all those terms, is care. It's looking after people with problems. And I think the other issue is, what is possible to know? Are there some things we're going to have problems actually researching? Again, during the day, we've had examples of actually trying to look at quite difficult issues. And I think the qualitative approach can look at some quite difficult issues, but it's more complicated. And it may be more difficult to get funders to consider it, and ethics committees to consider it. Have other people had the same problem? If you go to an ethics committee and it's a small qualitative study on something, spiritual care, they go, whereas the proper trial of a drug, that's much easier to decide on. So the sorts of research themes I'd like to go through, there's talk of the James Lint, the Priority Partnership Project. I was involved in an EU joint programme, Neurodegenerative Disease Research, JPNDR, which was a European look at what should be happening. We do have the National Institute for Care and Health Excellence in the UK, and they've had recommendations, particularly on MND care and MS. And I know has been mentioned the palliative care leaflet. And also has been mentioned, I've been involved in the consensus document from the European Academy of Neurology and the European Association of Palliative Care. And that was a challenge I'll come back to a little bit, but across Europe, where dementia comes is very variable. In Germany, dementia is a neurological disease, and neurologists look after people with dementia. In parts of England, it may be elderly care physicians. In other parts, it's psychiatrists for the elderly, or a mix. It's a very variable thing, and I think that's one of the challenges. If we look at the Priority Partnership Project, and it was mentioned earlier, out of those 10 main questions, there were certainly these 5 seem to come out as being important for neurodegenerative disease. The access to palliative care. It's come up again and again during the day. The advanced care planning. How do we look at, is this effective? Is it useful? Is it acceptable? The determination of patients' needs. We had a good example just now. And again, the assessment and treatment of pain when communication is complex. Now, that may be with dementia with cognitive change, but with someone with advanced motor neuron disease, there's the communication issue and potentially cognitive change. There were 83 long list questions. And in that long list, there was the best way of providing palliative care to people with dementia as a potential question. We come back to what is palliative care. And I think, is it specialist palliative care? Is it all of us who are involved with patients with dementia providing palliative care? Pain relief, swallowing problems at the end of life with neurology and dementia, drooling has been mentioned, management of agitation, assessment of distress, we talked about earlier, carer support was being hinted at again and again during the day. The training for carers, do we actually provide that proper education for carers? Or are in nursing and residential homes, are there young people who have perhaps even just come to the country recently, having no education in care at all, just being thrown in? Do we have continuity of care? One of the things I'm most proud in the NICE guidance for motor neurone disease in the UK is we've said that the social care provided for people should be from a small group of people who know that patient. Because does the same happen in Ireland, that the carer one day is different to the carer the next day, different to the carer the next day? And what families said to us is, we have an hour of care, but we spend 55 minutes of that explaining to the person how to do the care, and then they go and we do it all again tomorrow. The palliative care for non-cancerers, obviously, and understanding persons' needs with neurological disease and dementia. So I think this was, within this priority partnership, this was professionals and carers and patients all looking at what were the top priorities for looking at research. So we have evidence that we can use. The JPND had 2 workshops looking at this area and was very much involved in saying we need to look at needs assessment, we need to look at all groups. It isn't MND, it isn't dementia, it's all groups because there's a commonality. That there did seem to be, there were these transitions on a pathway. And was there a need of a good longitudinal studies to see what were the most important transitions? How could we help with those transitions or not have a transition? I mean, the transition everyone thinks about is going into institutional care. I think Adrian's project has shown that that may not be a transition if we provide good support. And we need to look early in the disease progression, not just at the end. We need to look at different health models, and looking at it European-wise means that we can look at different countries and different systems. What I think came over, there is no easy answer in any other country. No one else has got it. Everyone else is in the same boat of not knowing quite what to do. And the more I go to other countries, the more I can see that. Saying very clearly that palliative care is part of health and social care every day for every patient by every professional. And that's including symptom management. And we need to do the mapping and find out what makes it better, what makes it worse. How do we get that information? And trying to improve support across countries. Multi-professional work is quite difficult. Adrian hinted of the more teams you get involved, the more complicated it can be. Going to different countries with different languages, different attitudes, different whatever, makes it more difficult. But it can also be enriching, because it may be another area can give us really good information. We need to look at what works and what doesn't. There again, they were saying advanced care planning, and I've got a feeling that's something that's been going through the whole of the day, looking at the challenges of coping with cognitive impairment, looking at the effectiveness of education. You know, everyone does education. Does it actually alter anything? Does it actually change? I think the thing I'll remember most was it doesn't matter what's in your glossy brochure if the person's sitting wet, dirty, and not being fed properly. The same can happen. All our staff have been educated, but they don't actually change what they do. How much is primary care involved? And I think that's a challenge as things are happening across Europe. And involving voluntary groups. It's lovely that the Alzheimer's Society are here. We need to use voluntary groups to help support that. And they want to look at collaborative research problems across the EU and see how people work. Is there better early intervention? How do people anticipate end of life? How do we get this primary care, basic care, and specialist care? Now that may be specialist dementia care, specialist palliative care, but we have that balance of trying to get that right. And how do we particularly enhance and maintain continuity of care? In the UK, I find all my patients have problems on Sunday afternoons. Do you have the same problem? So the GP who knows them, the nurse that knows them, and the hospital team that knows them, they're not there on Sunday afternoon. Particularly this weekend, we have a bank holiday on Monday. So, this Sunday is a very good possibility that people will have lots of crises, because there's no one that knows them until Tuesday morning. So how do we get that continuity of care and enhance that? And how do we look at what's already there? There are studies on the population and disease-based cohort studies. How do we look at use those and look at particularly around diagnosis and long-term care? So I think the JPND was a challenge. I had hoped, being on that group, that we would produce our report, which happened last year, and then there'd be a big euro sign. And there would be this lovely email that would come, this is the report, put in your bids, we've got X million euros to give out, first come, first serve, send in the piece of paper and we'll give it to you. That hasn't happened. But it can be used with other funders to say this seems to be a priority, because it's looking into best practices, and they gave examples looking at good care. What is good care? What are the needs? What are the best systems? So NICE has also sets up research questions as part of their guidance. And the ones that we looked at in MND was looking at organisation of care. I mean, there is evidence in MND that multidisciplinary team clinics improves quality of care. Everyone thought, yes, that would happen. But improves survival by months. Much better than Riluzole. It's much more effective than Riluzole as the drug that may help MND. But multidisciplinary care increases survival better. So should we be looking at that in other disease groups? The assessment of cognition. How do we look at prognosis? Saliva management was again an issue. And do you find whenever I'm giving a talk about MND, I know the first question will also always be saliva. I actually have the privilege of actually talking about secretions to royalty. Fergie, Sarah Ferguson was the patron of the MND Association at one stage, and she came to one of the meetings, and I was talking, and they said, carry on, she'll just sit in the front. And so I carried on. I just got to secretions, and was just sort of explaining about thick secretions and thin secretions. The man with the button on and short hair and a button on his coat with a bulge under his arm went a bit green, at the back, the security guard, and she said, oh, come on, tell us more, So I thought I could have that as by appointment for secretions. About nutrition, about augmentative communication. And I think there's what I've gained and see more and more is communication is more than speech. It's more than words, it's more than aids. But we tend to get caught up on all of those. There's one speech therapist who has done wonderful things on communication in MND, where he's done videos of patient families. And a husband and wife will talk about what they're going to have to eat without any words. She just does that. And that's chicken wings, isn't it? Obvious, And that's what we do in families, isn't it, anyway? But it's encouraging those sort of acceptance of other ways of communication. With MS, there were things about particular drugs, but again, mobility, spasticity, cognitive rehabilitation, things that should be on the agenda. I thought I'd better say about the Irish, because I feel a bit, that there are only 2 or 3 of us who have come from abroad. Adrian and I have been keeping close together. But trying to look at the palliative care needs of people with advancing neurological disease. And we need to have better research, looking at that, linking it to the evidence, looking European and international and national. And I think it's a real challenge to look at all different disease groups and different symptoms, different problems, different psychosocial, existential problems, and try and see if together we can find more. Which brings me to my other advert, which is the AIIHPC consensus. It took ages. It's now on a website, on the European Journal of Neurology website, and is coming out in paper print very shortly. This was a group from the APC and the neurologists working together, which is been a bit of a challenge, particularly as I'm not a neurologist. So I get invited to these neurology meetings. The first thing I have to say is, I'm not a neurologist, and hope they don't notice. But next week, we're actually having, it's the European Academy of Neurology's Congress over the coming weekend. And we're going to have a memorandum of understanding between the APC and the AN signed on Tuesday morning, I hope. Phil Larkin is coming across as president, to try and get that link, to get palliative care within neurology much more stronger. And what we were trying to do was to say there is the palliative care approach. There is the need for advanced care planning. Don't forget families, don't forget carers. The bereavement care, the triggers for palliative care, and there may be, and what do we do about end-of-life care? And I'd just like to go through those one by one. I mean, I think, as was said, palliative care is early in the disease process, but it depends on the diagnosis. With MND, where you're looking at 2 to 3 years, you may be looking very soon after diagnosis. With MS, where the diagnosis may come and it may be 20, 30 years, it may not be specialist palliative care involved all the way through. With dementia, there may be particular times that more palliative care input is needed. But again, there is evidence from, there's the one study in lung cancer which showed that palliative care extended life. There are studies showing that I was involved with from Turin in Italy, where palliative care was shown to improve symptoms and did not increase the death rate. It's multidisciplinary team working, and it's multidisciplinary teams, because there is a tendency that the multidisciplinary team increases from 5 nurses to 6 nurses, or from 4 doctors to 5 doctors. You know, it is looking at medical, nursing, psychosocial, so it isn't just 1 or 2 professions. And it's having that access to specialist palliative care. And as I say, there are studies showing that that may improve survival. Communication, how do we talk with patients and families? How do we talk about advanced care planning? And I think it is a real challenge, advanced care planning. I know I was talking to a group of chest physicians, and I just said, how many of you have made a will? And there was a group of 50, and about 4 hands went up. If we as professionals don't do that basic advanced care planning. Interestingly, the professor of respiratory medicine emailed me the next week and said, I've booked my solicitor's appointment. I've done it now, because everyone was going to do it next week. You know, they've been wanting to do it next week for the last 20 years. And I think advanced care planning, we do need, because we're looking at communication changes and cognition changes, we need to be thinking much earlier if we're going to bother. How do we look at symptoms? There are the physical symptoms, looking and proactively assessing. You know, it isn't just waiting for patients to tell us. With someone with dementia, you're going to have to look at it. Families won't tell us about their psychosocial issues always. And it's just basic symptom management techniques. Carers, do we support carers before the death or after the death? And do we support professionals? English doctors have no problem with stress. We have the highest suicide rate, the highest alcohol rate, and the highest divorce rate, or very near to, but we cope with stress. And when I go around the hospital, I see an awful lot of the nurses outside the front of the hospital having a quick fag before they go in. We're not very good as professionals at actually looking after ourselves. Do we have the education, the support, supervision? Doctors don't sort of have supervision. The supervision and support tends to be in the King's Arms at 6:30. But do we need to build in support? I know at the Wisdom Hospice, if we had a real problem with a patient and a team, it would be the MND patient or someone with a neurological disease that was causing the whole team to disintegrate, and we needed to get them together. But we don't often do it. And end-of-life care, we need to be thinking about it, discussing it as patients want, and having an open discussion. And this is European, so we did say that there should be an open discussion about hastened death if patients are asking about it. Now, that may be patients or it may be families. It did strike me hearing Adrian's example of that person who said, I'm with my mother and I'm coping with her dying the day or two before she died, and this is important time. And she said thank you to her. If she had been euthanized 2 days before, she wouldn't have ever said that thank you, and that bereavement would be very different. In Netherlands, nearly a quarter of all MND patients have euthanasia, and another 10% have terminal sedation. And in some units, it's 50% plus have euthanasia. And I had a friend who was a Dutch nurse who went back to be with her mother, who was dying very peacefully, no problems, and the district nurse came in and said, I think it's time to get the doctor in, isn't it? Every day for several days before she died. My friend just said, no, she's settled, I'm settled, we're coping very well, thank you. We don't need the doctor in to provide euthanasia. Do we recognise that deterioration? Do we know when the dying phase is beginning so that we can alter our care? The Liverpool Care Pathway has been discussed already, and care pathways can be very useful. And we did, in an earlier group in the UK, look at were there triggers for end-of-life care for neurological disease. This wouldn't be quite the same for dementia, but it may be family or patient request, increasing dysphagia, cognitive decline, weight loss, repeated infections, in particular aspiration pneumonia. And I'm afraid we put in the gut feeling that we probably all have as professionals, something's happened, this person isn't as good. This was a consensus thoughts. So we have this is a small study, looked at the presence of those triggers from 24 months before death to death. And very nicely, the nearer to death, the more likely you are to have more triggers. So it may be this does give us, and from 6 months you've got several triggers. And even more important, that aspiration pneumonia is in the last 3 to 6 months. And I think for someone with MND, with MS, with Parkinson's, that may be the aspiration pneumonia is a sign that we're getting towards the end. And then we also said about training and education. I think that's a joint thing, that neurologists, elderly care physicians, old age psychiatrists need to know about palliative care, but palliative care professionals need to know about neurology and dementia and the issues. It's both. And I think we tend to think, oh, well, we don't need to know, we can just do it. But actually we need to be learning in the same way as we're asking others. The other aspect, I think, is that the number of teams that people can get involved with. And I think teamwork, we talk about our own teams, but there's this interaction with other teams that can be as big an issue and a big problem, because we tend to assume other teams work like us. But actually, they may not. They may work in a different hierarchical way. They may have different attitudes, different feelings, different systems. And we never think of that clearly enough to see how things are. So this is Peter Bede, who was in Dublin, I'm not sure where he is now, who came up with this idea of, when I started, it was neurological care, you had neurological care, and then I would get the letter, I'm very sorry, I've got to refer this person to you now, David, for palliative care, at the end. That stopped quite soon after I started. This was quite a long time ago. And we did have that sort of, the two triangles, that as someone got iller, perhaps you had more palliative care. And he suggested quite a few years ago that actually it's more complicated than that. And actually over a disease progression, there would be times you would need more care and then less. Now with MND, that might be at diagnosis, when someone's struggling with the diagnosis, a gastrostomy, at non-invasive ventilation at the end. And that might be in 2 years. For someone with MS, it may be severe spasm pain, severe swallowing problems, other problems over 30 years, and anything in between. And I think this is a challenge both ways round. It's a challenge for people involved in the care of patients with neurological diseases and dementia to be open to talk about dementia, to talk about palliative care. And there is still not them down the hospice, you know what they're like. I don't want to upset people by mentioning palliative care. But there's also from palliative care saying we don't want to be overwhelmed with all these people we don't understand and we don't know what to do. So it's a challenge for both of us. And it's also a challenge that no group is going to be involved continuously doing everything necessarily. It's going to be working within different teams. So what are the challenges? There is a challenge. We need to look at how we look at this recognition of needs, of patients and families, of carers, of services. And there is this need to look at how we all collaborate, whether that's neurology, geriatrics, rehabilitation, general medicine, primary care, specialist palliative care, and all that involves, and all those problems of integration and collaboration. And I think that gets more difficult as I get older and see within the NHS in the UK, everything needs to be in little boxes. You have this or that or the other. And it gets very complicated if you don't quite fit into all the boxes. Because someone with dementia may have heart failure and COPD as well as their dementia and frailty, and that's all different people. That's too complicated. So we need to be looking at how we provide the total care. And I think Adrian's example was, having a care system that provides that support for families so that on the Sunday afternoon they know who to call, how to get help. People who are around them know who to call, how to get help. So I think it is a challenge, and I hope that some of those areas are something we can come back in the bigger discussion now to come up with some key research topics that we could do. Thank you for listening.